Professor Wu, Professor Chin, I'd like to thank you both and Cisco for inviting me to be part of the faculty at this very inspiring meeting. I also would like to thank Professor Wu for the visit to Guangzhou General Hospital this morning. I was really, really impressed by what I saw there and the enthusiasm and passion of your staff, and what they are doing for cancer patients is remarkable. And congratulations to you and to all of them. So the topic that I'm opening up with is on ethics in clinical research, which is really very, very important because there are some major challenges around ethics and how we go about the important clinical research work and clinical trials that we do. What I want to do during this talk is explore the ethical tensions in the investigator-subject-patient relationship, talk about the systematic approach to evaluating ethics in oncology trials, understand how we can improve the consent process for cancer trials and clinical research, and also then finish by considering real challenges that are raised by conflicts of interest in oncology research. And sometimes those can be unintentional, but nonetheless very important. The history of research ethics is full of potholes. We have actually come an awful long way in clinical research, clinical trials, clinical experimentation over the course of the last 40 or 50 years. And in some respects, partly because of new technology in medicine and medical science, we are probably even more challenged today in how we approach this subject than ever. This evolution has happened through some of the medical experimentation that took place during World War II and the experiments, human experiments that the Nazi operation did. But there also have been other major challenges to society, ones which were going on in the US and indeed in Europe, which we actually didn't know about until retrospective analysis brought those to light. So the Willowbrook hepatitis studies, these were done in handicapped and intellectually challenged children who were institutionalized in Staten Island in New York. We had the Tuskegee syphilis studies that were done in black females back in the 30s without their consent. And of course, we also then had trials done on particularly women with AIDS, where the actual results of the trial, or what should have been done, was known ahead of time. And that was actually in the late 1980s and early 1990s. Henry Beecher's New England Journal article, he was a physician. Indeed, he was a man who was controversial in his own time. But he exposed in the New England Journal in 1966 a series of studies done in some of the New England hospitals on patients without consent. I'll pick out one. There were 22 that he wrote about in this article. It's well worth reading. One was injecting patients with cancer cells. They weren't actually told they were cancer cells. They were just told they were cells. So you can sort of see the types of challenges that were faced. But nonetheless, these led to then, all of these events led to a number of very important regulatory codes that developed, beginning with the Nuremberg Code, which really came from the review of the clinical experimentation that was done by doctors under the Nazi regime. That facilitated the creation of social values and determination of levels of risk and benefit, and the first element of what was termed informed consent. However, large elements of that code were not really implemented for at least 20 years, and it was really beginning in 1960 that the Nuremberg Code around clinical research was re-explored by the International Office of Medical Science. And that then, over a period of 4 years, led to the Declaration of Helsinki, which demanded written protocols around clinical research protecting patients, also demanded independent review and the creation of what we now know as institutional review boards or research ethics committees, but also then widened the issues around informed consent. In the 1970s, we had the Belmont meeting. Belmont, just outside Maryland, was a review of medical ethics that actually came from things like the Tuskegee Syphilis Project, as well as the Willowbank, because those only really got exposed in their full implications in the early 1970s. And that then brought forward the issues of justice, beneficence, in other words, do no harm, first principle to the patient, and the other issue being fair subject selection. And these really now, I suppose, underpin the whole ethical framework within which we do clinical trials and clinical research today. What's the definition of clinical research? Well, this is important because it actually fundamentally frames how we come at the whole issue of clinical trials. Clinical research is a class of activities designed to develop or contribute to generalized knowledge. It's not necessarily there to better the patient outcome, because you don't actually know what the patient outcome is going to be. Otherwise, you would not be doing a clinical trial. Clinical practice research is different. It actually looks at interventions that are designed solely to enhance the well-being of an individual patient or client. And of course, as physicians and doctors, health professionals, we do confuse these two things, and I'll point that out later in my talk. But it's very important that we actually break these things up and look at them carefully, because doing a clinical trial is not about improving the outcomes for patients necessarily. That's obviously what we would hope for. Now, obviously, we have the clinician, the investigator, and the patient. The clinician has a real challenge because the clinician, all of you, have dual allegiances. First of all, you may be the PI, the person who's come up with this great idea, so you'll probably have a very strong allegiance to your actual clinical study. You also have a very strong allegiance to your institution, and it could be the research group that you're working with, whatever, but that allegiance will also be very powerful. Of course, you will have a very strong allegiance to your patient, stroke subject, and these may actually create a legitimate conflict, one that you have to step back from and ask the question, am I really doing for the patient what's in the best interest of the patient or subject? Because in some cases, increasingly in oncology, in my view, we may sometimes be dealing with people who are not patients. And we see that in many other areas of medicine today. So it's very important that we should be aware of these tensions. I want to point out an example of conflict, one that's actually very close to myself, and I'll tell you why in just a minute. Many people in this room will remember the NSABP trial. It's a breast cancer trial. Back in the 1990s, a PI at St. Luke's Hospital in Montreal falsified procedure dates and hormone receptor status so that breast cancer patients would appear to meet eligibility criteria for a clinical trial. In actual fact, what the investigator did was he enrolled patients into the trial who were 6 weeks out of surgery rather than 4 or 5 weeks out of surgery. So they were a week to 10 days post-eligibility in terms of entry. As part of the hearings into this, because in actual fact, this particular episode virtually ruined one of the most eminent breast cancer physicians, surgeons in the United States and internationally, Dr. Bernie Fisher. It also called into question other trials done by this organization, which had led the way in terms of breast cancer for the best part of 30 years at that time. The PI's response is very revealing. He said, "My sole concern at all times was the health of my patients, as every physician would. I firmly believed that a patient who was able to enter into an NSABP trial received the best treatment and follow-up treatment." He probably was right about that, but he was making a clinician judgment. For me, it was difficult to tell a woman with breast cancer she was ineligible to receive the best available treatment because she did not meet one criteria out of 22. The problem was he did not know that that was the best available treatment. He had already prejudiced himself and indeed endangered the patient by coming at the clinical trial in that way. The other reason then that this is such an important trial for me was a huge learning outcome, because I had just published, as some of you in the room know, I did a lot of work on thymidylate synthase in my early career. I had just published a clinical paper 6 months prior to this breaking out with Bernie Fisher, the PI on the overall protocol, and with Bruce Chabner, representing the organization that was funding this trial. As a result of that, all of my files were subpoenaed. All of my investigations around thymidylate synthase for 4 years. I had federal investigators who came and took 20 boxes away from my lab, gone for 6 months because of that thing, because of that fact. So it points to the wider ramifications of what we do within clinical research and their importance, not just for patients, but for the integrity of the whole process. There are 7 major criteria for ethical research, and I'll go through these now in some depth. They are social value. What's the value? And we'll come to that in a minute. The scientific validity and how that is measured. The fair subject selection. In other words, are we being transparent and critical about who's going into the study? Is there a reasonable balance of risk and benefit? Independent review. No longer the jurisdiction of only the investigator. It has to go for independent review. The issue of informed consent. Are the patients or subjects going into a clinical trial properly informed of what's going on? And then finally, respect for enrolled subjects. And I'll come back to each of these in a minute. First of all, social value. The study itself must ask an important question. If you have clinical equipoise, as it is known, and if there is no basis upon which the null hypothesis should be framed, then in actual fact there's no reason to be doing the study. The question might be an interesting question, but if it's already known in the literature, then in actual fact there may be no basis upon which to go forward. Equally, ask the question, is the study going to be value for improving health or basic scientific knowledge? In other words, add to that greater value in a very concrete way. The research itself is asking a trivial question. If it is, then it's not something we should be investing in. Has the question already been answered? And those are very fundamental things that have to be answered before a study goes forward. The scientific validity. So even if the question itself that you're trying to address is important, the study may be unethical if your methods and the thing that underpins those methods are actually not well designed. So first of all, if it's not feasible. So in your institution you don't have enough patients to put into a particular trial, you don't have the right collaborations, there aren't enough patients in that disease category to actually allow the trial to happen. There's no point in opening that trial, because in actual fact you'll put patients in, but you'll never ultimately answer the question that the trial has been designed for. For measures, the structures around doing the trial actually are not properly framed. In other words, the training and implementation process are not structured properly and not quality assured. Have you got adequate sample size? We talked at lunchtime about the importance of biostatistics and statistical design, increasingly important. Well, that's your starting point. What type of population size do you need to actually address the question? And there's no point in going forward if you don't do that. Per statistical analysis, I'm sure we're going to hear a lot more from Jack Lee about this, but if the underpinning statistical premises are all wrong, then in actual fact, that's also unethical. And then biased reporting or non-reporting. one of the challenges we've had in the oncologist is thinking about trials that nobody wants to actually publish. Why? Because the results weren't positive. That doesn't mean that those studies should not be disseminated and the information in them. In actual fact, there's an element of ethical debate around not publishing negative studies. Why? Because that information needs to be in the public domain so that others can learn from it, and in particular, patients can learn from it. And if you're never going to disseminate or publish the study, why would you ever have the ethical basis to start the study? The issue then of fair subject selection. Historically, we can all point to many different stories where the issue of fair subject selection has been a major issue for society. That has been predominantly around ethnic minorities or mentally incapacitated or institutionalized types of individuals. We also, of course, must make sure that we're not excluding certain groups from research. So children, pregnant women, yes, they may be more challenging, but nonetheless, they should be part of our studies in a credible way. Now, that's more of an issue, I have to say, particularly for children in other diseases. For pregnant women, it certainly is an issue for oncology. But it is not right to exclude them just because their issues around treating them are more challenging. Weighing up the risk-benefit balance is a huge issue. And that risk-benefit balance may tip one way or the other depending on the disease context. Do you think we would have been able to do allogeneic bone marrow transplantation in 2012 in the way that was started in the late 1970s? I think the answer is most definitely not. Do you think we would be able to do pox vaccination, which has eradicated smallpox throughout the world, the way it was done in the late 1700s, early 1800s by Jenner? Absolutely not. So how we as a society weigh up those risk-benefit ratios for subjects is really important. And of course, I'll come to this in a minute, that's the role of our institutional review bodies. They actually must look at this very, very carefully. And of course, what those risk-benefits may be very different in Western world to Africa, India, or indeed to China. So societal benefit actually may be also measured differently. So the institutional review boards are really important because they fundamentally are what approve studies. Research ethics committees in European and UK setting, which I'll talk more about tomorrow. And what they must do is they must judge this balance in terms of risk-benefit. Are the risks to subjects reasonable in relationship to anticipated benefits, if any, to subjects, and the importance of the knowledge that we may reasonably be able to expect as a result of doing that, be that positive or negative in relationship to the clinical outcome. As I've said, the institutional review boards are really critically important. They are mandated by federal regulation for most research with human subjects. They review studies at their inception, weighing up these issues that I've talked about: science, risk-benefit ratio, informed consent, which I'll come to in a minute. And they also, of course, very importantly, monitor the studies as they proceed, with continuing reviews, amendments, monitoring adverse events, and indeed the unanticipated problems that come forward from them. In the European setting, research ethics committees safeguards the rights, safety of people participating in research and well-being. They also review applications, as the IRBs do, and give an opinion about the proposed participant involvement and whether the research is ethical. Like IRBs, RECs are completely independent of research sponsors and investigators. And in the UK, which is the clinical context I work in, there are over 6,000 of these applications each year. Now, informed consent, another extremely important component of ethics in clinical research. First of all, as I've already talked about, we have to ensure respect for individuals, for their values, and their preferences. be they cultural, personal, religious, etc., in the decisions about their medical care and their participation in clinical research. And therefore that demands for us as clinicians that we have respect for the patient and their autonomy in that decision making. This, of course, is not a one-time issue, it's an ongoing issue, because we've all had patients who've gone into clinical trials and who, for a variety of reasons, have decided to leave trials, and that is their right. We've other patients, of course, who've said no to a trial initially and then subsequently wanted to join. So the components of valid consent are, first of all, that consent is voluntary, that it's not in any way undermined by coercion. In other words, that can be subliminal, and we've got to be careful with that, because all of us probably do come with our own baggage, with our own belief in terms of what the clinical trial may be trying to achieve. So not coercing, presenting a very balanced view to the patient is very important. Incentives for patients, of course, have been very controversial and have been used in the past to actually enroll patients into clinical trials. And of course, we've all had the spectrum where we have someone with very advanced disease who is grasping at straws, and that's where we find real challenges in terms of ethical behavior. Certainly, I've come across it, and I'm sure all of you have as well, where people are mortgaging their house, their family, and everything to go into things that have never been set up properly or are never going to provide benefit but are being sold in that way. The other thing is, does the patient have the capacity to actually make those decisions? And that's a big, big issue. How do you really determine that? Sometimes those can be very, very difficult decisions. Are we giving full disclosure in relationship to the information underpinning the reason we're doing the clinical trial? Final decision, however, remains with the patient in a fully consented way. So with the patient, we have to be completely transparent about the nature of research, its purpose, and its likely duration, procedures associated with it, and what the risks around those are. We also should make people aware both of the benefits, potential harms to themselves and indeed others, what the alternatives are, obviously the implications for confidentiality. We should also talk about potential related injuries, whether they are indirect or direct, and around the whole structure of the trial, make sure that all of the right contacts are in place so the patient has easy access to the clinical system. However, we must guard against the therapeutic misconception, which I've alluded to previously. The belief that the purpose of a clinical trial is to benefit the individual patient. It is not. It is there to gather data for the purpose of contributing to scientific knowledge. However, it is not a misconception to believe that participants probably will receive good clinical care during research. We all know there are multiple clinical trials or multiple publications demonstrating that outcomes for cancer patients are much better when they are enrolled in clinical trials. So it is a misconception to believe that the purpose is to administer treatment rather than to conduct research. And that's a really fundamental principle. Some of the factors associated with improving understanding are, first of all, the relationship between the patient and the doctor. The discussions must be in primary language. What that means is a language that the patient or subject can understand. And sometimes we forget that as clinicians because we're used to the language we use. And certainly, I think all of us have experienced talking to patients, and on the first or second occasion we see them, we give them all this information, and then the next time we come back and we have the real conversation because they only heard the first 2 or 3 lines or the first 2 or 3 minutes of what we actually said, particularly around giving someone the initial diagnosis. So we've got to be very conscious of that. We've also got to be very conscious of what the educational socioeconomic status of the patient is, and also the age group of the patient. We must give patients the opportunity to read the consent form carefully in a template that is easily understood. If possible, have third parties present so that they can have fuller discussions with them and have very readable forms, and indeed even have an educational process around clinical trials for patients, which we just instigated 6 months ago. The structure of consent has to be planned. It can't be something that's rushed. It must clarify how participation in the study differs from standard care. It's got to be honest about uncertainty, because particularly with cancer patients, we have that balance between ensuring that hope stays eternal, but that there is uncertainty. And that balance is a very difficult one at certain stages of the cancer journey. And also discuss how participation serves both the subject good, but also a broader critical public good, and one of the reasons why we are all here. That is underpinned by making sure the patient, first of all, has a very good understanding of disease and clinical status relating to themselves, understands the current treatment and state of the art, and then understands fully the clinical trial. In writing a consent form, we must ensure a structure and a template, and starting that with, "We are inviting you to." It's an invitation to join. It's not something we are demanding or coercing. The conversational style has to be friendly, and, as I've already said, the consent form has to facilitate easy reading. Now, on the issue of respect for subjects, this is very important, because the reason we're doing the clinical trial is we're trying to answer a question. We don't know the answer to the question as yet. It's an important question. But the patients going into those trials actually are the very ones who are answering that question for us. So therefore, we have a responsibility to share new information that comes to us ongoing through the trial. We must avoid, as investigators, conflicts of interest. I will come back to that later. We must maintain confidentiality with the patient. In particular, we have to show gratitude for subjects and their contributions to clinical trials. And it is only in recent times that at podium addresses that we've actually done that. A lot of us would have got up and presented trials historically, given the results, but never really acknowledged the patients who actually were the ones who answered the questions within the trial. And of course, most importantly, the patients or subjects have a right to know what the results are. Let me spend a couple of minutes now on conflicts of interest. A really, really important and tricky area for all of us. So, what's the definition of a conflict of interest? Well, it occurs when a professional judgment concerning a primary interest tends to be unduly influenced by a secondary interest. And therefore, I'll give you some outlines of what primary and secondary interests are. They're shown on this slide. First of all, the primary interest is to develop valid, valuable science and clinical science, including the dissemination of those clinical results that I've already talked about. The other primary interest, and probably even more important, is the respect and welfare of the patients. However, there will also be secondary interests for clinical investigators, which will be non-financial. We all want to be promoted to professors, so they tell me anyway. Publications, of course, very important to underpin and develop one's career, and of course, for one's own personal prestige and that of the institution. Those can be real conflicts. And of course, the financial spectrum, both in terms of research funding and making sure that you keep your research program alive, and indeed both personal and non-personal income rewards, we have to be very, very wary of. So this balance of conflicts in here is one that's alive and one that we have to pay careful attention to. What are the potential consequences of the conflicts of interest? Well, first of all, if these things collide, we're usually to blame because we haven't stood back from the clinical situation, the clinical trial, being transparent and open enough with what we are doing with ourselves and with our patients, with the institution and our colleagues. They result in decreased communication of research findings and scientific openness. And if you reflect on that, it's really important because you're probably actually trying to hide one thing to demonstrate another. They also, and probably most importantly, lead to biases in research around design, the conduct of the trial, the length of time it's done, indeed the analysis and the way it's done, and also, as I've already alluded to, reporting. But fundamentally, in my view, what it does is it increases the risks to our patients and to human subjects in trials under our care when we get these two things wrong. And it's one of these things that, as I say, sometimes unintentionally we can make these things collide. And that's why we have to spend a lot of attention on this area. The conflicts must be avoided where possible. If they are there, we've got to be completely transparent about it from the start with our IRBs, regional ethic committees, and with our institutions. And in industry-sponsored research, we must ensure that the contractual rights to data access and publication are there. Otherwise, that research is only going to benefit the industry and nobody else. Now, let me give you a case which, in my view, underpins a lot of the issues and challenges that sit here. Patients with imatinib refractory GIST. Imatinib, as you all know, transformed the lives of patients with GIST, which prior to that was basically an incurable disease. In the US, patients were offered participation in a randomized control trial of the multi-targeted kinase inhibitor, sunitinib, or Sutent, and it was set up as a Sutent versus placebo in a imatinib refractory population, and open label access to drug at progression was the design of the trial. Two institutions, MD Anderson, Jack was one of them, and University of Michigan refused to do the study. There were very good reasons. There's nothing wrong with refusing to do a study at all. But what was interesting was the comment from the lead associate investigator at the University of Michigan as to why they weren't going to do the study. Because what he said was, when patients have an advanced cancer, the cancer is growing, there isn't any way a placebo can be helpful to the patient. To argue that a placebo trial is in society's interest has nothing to do with helping these patients. Now, there's nothing wrong with that statement per se, but what it does do, it goes to the heart of the misconception that actually a trial is there to benefit the patient. We don't know the result of the clinical trial. And therefore, when you reflect on this case, the purpose of the study, and all studies, is to validate the efficacy of a new intervention, a new drug, in this case for imatinib refractory progressive GIST. It's not there to necessarily be helpful. We as physicians and healthcare providers want it to be beneficial to our patients, but we don't know that. If we did know that, we wouldn't be doing the study. The critical questions, however, are, will the participants be worse off inside than outside the study? Is there an alternate design that can actually answer this question and provide a valid answer without the placebo control arm? That's a very reasonable question. And does design minimize risk and maximize benefit consistent with obtaining important and valid results? So in conclusion, ethical guidance is needed, and even more so going forward, in my view, to prevent exploitation of subjects in research. These 7 principles that I've outlined offer a systematic approach to determining whether a clinical study is ethical or not. Balancing these principles when applied to particular trials can be complex, and clarity about conflicts of interest are absolutely vital and will help all of us navigate this really difficult issue. Thank you very much.
Just now, Dr. Patrick gave us a wonderful speech, talking about consideration in clinical trial. Any question? Do you have any question? You can raise your hand.
Enjoyed that very much. I'm, as you know, a phase 1 oncologist, and I saw in your slide the tumor biopsy, which has really been a very challenging issue. On the pro side, you want to do the tumor biopsy because you have to have the proof of mechanism, and you just cannot make the go, no-go decision without that tissue. And if you make it optional, most patients would disagree or not consent, unless you really obviously do your explanation and they understand that it's crucial to understanding the mechanism of the drug. There are trials definitely that says if you do not do the biopsy, the patient cannot be enrolled, unless it's medically contraindicated, but that's a bit subjective. How are your views on that?
Well, that's actually why, Lillian, first of all, it's a great question and probably one of the most important questions for us going forward in cancer medicine. It's why I made the comment that I think ethical issues now in clinical trials are going to become even more complex. Because it's not just one biopsy. In the types of trials that you're talking about, the nature of phase 1s is going to change over the next 5 years. They're not just going to be about toxicity. They're going to be about defining molecularly the populations we should really be targeting. And the only way of doing that is either by looking for biomarkers, either from serum, plasma, or direct biopsies of tumors, and possibly sequentially, because some of our treatments may change that molecular context. So this is a really, really challenging one. And therefore, it demands complete transparency as to why we want to do this. We won't know that it's going to be of any benefit. Some of the assumptions that Jack's going to come along with in terms of adaptive designs are based on the information that we will be getting from these biopsies. So these are absolutely critical. My view is that we have to be, and put it in layman's language, why getting this information is critical to answering the particular question that the clinical trial is derived for. As long as we come at it that way, then we will be transparent and we will also allow the patient to engage fully. However, there may be patients who don't either understand that, who cannot grasp that level of complexity, or who are frightened by it. And it will be up to them to decide whether they're going to consent or not. And that's as it should be.
Patty, if you allow me, could I make an editorial comment about a very important topic you alluded to or actually addressed, and that is the non-publication of research results derived from a clinical trial, and the very real possibility that to not release that to the public domain through peer-reviewed publication may itself be intrinsically less than ethical. I'm not saying it's unethical. I'm saying it's not fully ethical. And there are reasons that are given either by institutions or by pharmaceutical companies. Let's take the latter. A pharmaceutical company may not want to have negative trial data released because it might reveal or lower their competitive position, or at least the perception of it. A institution may not want that negative trial released because it might lessen their prestige or other reasons. That no longer, I think, is a tolerable circumstance. And I'm very pleased, at least in certain instances in the world, there are pharmaceutical companies, some of whom are represented in this room, that are actually now pooling their data. A group of companies are actually providing all of the comparator arms of prostate cancer clinical trials, all of them that they have done in a transparent way for investigators to go in and actually research. And the results of that will be then publishable. So I'm submitting to us that each of us, whether we're investigators or whether you're from industry, we have to change our thinking. We really must publish. If you're editors of journals, find ways that your journal will accept papers that might be defined as negative. Because, in fact, what Professor Johnson has just taught us is that the very most important thing ethically we must consider is the patient. When your patient consents and signs a dotted line, I accept your invitation to enroll in a clinical trial, that patient has an understanding that the results will be useful for society and not sit in a book of results on an investigator's shelf. It must be contributed to society. So in order to honor patients, we must publish. Thanks for that opportunity, Patty.
Not at all, Marty. I think it's a really important point. I mean, I did push it a little bit in saying unethical, but I do actually think there's an ethical challenge. If at the very start you're not likely to publish a study either because you aren't able to answer the question because you don't have enough power in it, or because it's negative, then you do have to pose the question, should you actually be doing the study? Well, I have to say I would submit that no, you shouldn't.
Okay, thank you, Professor Patrick. Thank you for your presentation. I have a question. So what is the special point or special consideration for the ethical consideration in the cancer clinical trial compared to the other diseases such as cardiovascular or diabetes, other studies? Thank you.
Well, there are a number of different special concerns that come around cancer patients. First of all, for phase 1 studies and indeed for third, fourth line studies, and even second line studies, we are dealing with patients and individuals who may be very worried about their clinical context, and indeed, I use the word desperate. Certainly I have had patients who come with that countenance and who you have to reassure, and so therefore their ability to stand back and make real judgments for themselves can sometimes be diminished because of their clinical circumstance. You also have to look at the support mechanisms that cancer patients have both at home and around them, particularly when we're going into complex studies, because that may demand frequent visits to hospital, which may interfere with quality of life, because they're not able to spend the same amount of time with their families. And indeed, all of us can cite examples of people that we have advised to come off study because we felt that their either performance status has got poor, or indeed they may be in the last 3 months of life and it might be better for them not to be on study. So the clinical decision-making process with the patient in the setting of clinical trials for cancer patients is a more challenging one, and that's the one I would probably highlight most. And again, it's one we are there as clinicians to support the patient and to do what's best for the patient. Sometimes balancing that then with our desire to finish, complete, and answer an important clinical or scientific question can be very challenging.
Yeah, so I have 2 quick comments and one general question. Just following Dr. Murphy's comments, I have a real example of a negative study which a company doesn't want us to publish. So actually, maybe 5 years, it was like the trial lasts for about 4 years. It's a shark cartilage trial in lung cancer.
Oh yeah, I remember this one.
Yeah, and then, so we really conduct the study very rigorously. At the end, we found there's no benefit, but the company keep dragging our feet and say that, you have to do this one more analysis, look at this subgroup, do this and do that, make sure that there's nothing. And eventually, at MD Anderson, we have another committee, which I will also touch upon briefly, is the Data Monitoring Committee, or DSMB, Data Safety and Monitoring Board. So basically, every clinical trial will need to be reviewed by this committee. And one of the jobs of this committee is make sure that the data is analyzed and published. So eventually, we got that paper published at JNCI. So that's the first comment. Second comment is, Dr. Johnston, you alluded to this adaptive design, which I will also talk a little bit more tomorrow. I think we are in 2012, and those Belmont report, and of course have of great importance as you outlined. That was done in the 70s, okay? And we need to learn from the past, but we need to move on to doing something more relevant, more creative. So I totally agree that we need to convey to the patient clearly that the patient participating in clinical trial may not get benefit because we don't know the answer. We don't want to mislead them, say that, they will get the best treatment and then their cancer will be cured. Okay? And we need to provide the right information. But there's a trade-off between this thing called group ethics and individual ethics. And that's the difference between the equal randomization versus adaptive randomization. Maybe you can comment a little bit on that. And lastly, is I really like to hear from our Chinese oncology colleague, what's the most challenging ethical consideration in clinical trial in China? What do you face? So,
Two great questions. First of all, to completely agree with your comments, the group ethic is one that actually we're used to dealing with. The individual ethic is actually now the more challenging one. And part of the adaptive design is you make certain assumptions in adaptive design. Some of those sometimes are built on preclinical evidence as opposed to clinical evidence. And you then have to do the first adaptive component to take you to the next adaptive component. And so therefore, you're into much smaller group studies to allow that to happen. And therefore, the patient understanding that initial adaptive design may lead to something that no one ever expected, which might be negative rather than positive, is something that we haven't had to cope with to the same extent before. And that's where I think the complexity around the molecular characterization and its implications for patient treatment going forward are going to be really, really important. So it's a really good point, Jack. Does somebody want to answer the second question? Because I think I know time is up, but I think it's a really important.
So the second question for all the Chinese participants, who answer this question? Yeah.
我用中文。
Okay. You can use the Chinese, no problem.
谢谢江信。我同时我是医院的伦理委员会的委员，这样的话我就会有机会要参与一些医院的各个专业的伦理的通过。那刚才我们也看到了伦理它。
My hospital, so we see that the scientific value and also. I'm also working at the Ethical Commission at my hospital. I'm on the Ethical Commission. There are a lot of different proceedings or procedures of ethical review that I have participated in. So in terms of the ethical aspect, I think because of there is a scientific value, when, for instance, we are doing a new clinical trial of a new drug and placebo, then how do we really embody the value or benefits that we can provide to individual patients, because we are doing the comparison of placebo and a new drug. So where is the value or benefits for the patient?
Okay, well, so the question is around a new drug versus placebo type of trial. Yes. And how do we actually demonstrate to the patient the benefit of the new drug? This is a really important question, and I'll go back to what I said during my talk, that in the clinical trial itself, you cannot point to the benefit of a drug, because if you could, then why would you be doing the trial? In the context that you portray in terms of versus placebo, the more important thing is it ethical to have a placebo? Because in actual fact, because you have a placebo, you may be doing harm. And that's the context that you have to look at very carefully. So in other words, let's look at the serotonin antagonists, Genesitron. Initially those antiemetic trials were set up back in the mid-1990s, late 1990s, we had very good regimens to actually control emesis, particularly in platinum patients. However, the question that was posed there was it ethical to have a placebo control arm? Initially, there were 2 trials that were done with a placebo. They were stopped because it was felt that, in actual fact, it was unethical in certain categories of patients being treated with platinum in particular to continue those trials. Now, we know that ganestotron and the serotonin antagonists turned out to be very, very important and very good antiemetic drugs. But the critical thing was we didn't know that at the time, number one, so we couldn't demonstrate the benefit to patients. So when we went into the trial, you cannot tell the patient that there is likely to be a benefit because you do not know that. Now, you may have preclinical evidence, you may have animal experiments, etc., that give you an indication, and you may even have phase 1 data that you can point to, but you cannot give that a level of authority in relationship to the clinical benefit, because if you could, then your trial, by definition, should not be done. You've reached the clinical equipoise. It's there. The null hypothesis has already been answered. You don't need to be doing the trial. So in that context, the bigger issue is whether a placebo is actually ethical or not.
So I tried to answer the questions about the Chinese I did consideration. I think for the international clinical trial or the new drug trial in China, though we have the same standard for the GCP. But for the IIT, especially for the new so-called new technique, such as stem cell treatment, I think we have the very big problem in the China. Yeah. So this is a different assets. So follow the willingness. I have the one question about the cancer tissues. Because so far so the driver gene is very, very rare, the evidence, such as the crizotinib, only 70%. So we screened so many patients, 97 patients don't know to get any benefit from this the biopsy. Only 7 patients. Later, maybe 2% or the 1%. So how to consider these IDs issues?
So again, these are really the critical issues. And it goes beyond biopsying for trials. This goes into mammography. How many people do you have to screen to actually demonstrate the benefit? I think the important thing in that context, where you can define those 4 to 5% with the ALK fusion, where you can actually say these are the patients who will benefit from crizotinib, is that the therapeutic benefit in that subgroup far outweighs anything else. So what you're doing, therefore, is you're actually excluding the other 95% because you know they don't need that therapy. And so what the benefit there is that you're not putting them through a therapy for which they will gain no benefit. And so where you have a test that has been demonstrated to therapeutically select with the level of benefit response that's been demonstrated for crizotinib, then ethically the risk-benefit ratio is there. But equally, there are other settings where you've got to look at what that risk-benefit ratio is, and that's where we're going to need actually both statisticians, public health officials to actually address some of those things, and it comes back to the importance of the IRB review. It is absolutely critical going forward that is done in a way that begins to address those types of questions, but it highlights the complexity of the types of questions that we're going to have to address.
One more question, last one.
Yeah, in terms of the questions by the Jack, I have actually I have one ethical dilemma. More and more drug developing in Western country, and the pharmaceutical company want to do the clinical trial in China quickly. And they always complain about the SFDA, the long process day, and usually SFDA needed to do another phase 1 trials in China. Usually, the pharmaceutical company just supply the phase 1 data based on the Western population. We know that different population will have the different, pharmacodynamic data. So is it necessary to do another phase 1 trials in China, or just that we can, use the data in Western country, or even maybe we can use it in Japan or in Korea? So give your comments.
Well, my view is that you have to look very, very carefully at the phase 1 data, populations that have been enrolled in phase 1 studies and what's been done around those. And I absolutely agree that taking Western phase 1 data and applying it to China is fraught with very significant risks. And probably in most contexts, yes, you will have to do some element of phase 1 development. But I actually would turn that into an opportunity, because I think actually this is probably one of the biggest opportunities you do have. Because for us in the Western world, we don't have the population size and patient dimensions that you do. And so therefore, if you take the ALK fusion protein, small population numbers, but you have the numbers, we don't. We will struggle to enroll in some of these trials and for some of these mutator phenotypes that are going to be pulled out over the next 5 to 10 years and that will define therapeutics. So yes, I do think that on balance you probably will have to do some elements of phase 1. May not have to be large scale, but it certainly will have to be intensive, because there are differences in metabolic genes and other genes, but it will depend on how the previous phase 1s have been done.